Hi, this is Junaid. In this lecture, we're going to discuss indications, contraindications of IVtPA. We're going to discuss only the 100% true indication for giving TPA or near 100% contraindication to give TPA. In the second part of this particular lecture, we're going to discuss the maybes and then strongly work it to give TPA or not to give TPA. So let's start with the contraindications first. The reason behind is that we need to make sure when not to give TPA, because that's where clearly the patient safety issues comes in. So the first and foremost is if the patient actually has a mild stroke defined as an AIS stroke scale less than 5 and non-disabling defined as patients who will be independent of their ADLs and will have returned to work. If that is the case, then it is considered mild non-disabling stroke. In those situations, you should not give TPA. The whole lecture is coming after these two lectures about mild strokes and the theory behind all of that. So the second, of course, is if the CAT scan already shows consistent hypoattenuation of the stroke territory that you already know. So in these cases, when you're looking at patients who already have, by definition, completed the infarct, then clearly giving TPA in those cases will cause harm and not benefit. Now, there are patients who have older strokes on the right side of the brain and now coming up with the new symptoms on the left side. We're not talking about those patients. We're talking about the symptoms are consistent with that territory of the brain in which the hypoattenuation is clearly visible. That means that area of the brain is stroked out. And if that area of the brain is stroked out, why are you giving TPA? Because that's not going to help. So clearly in that situation, it is contraindicated. Intracerebral hemorrhage with previous history of any intracerebral hemorrhage anytime apparently is a contraindication. And that is something that you have to have a conversation with the family and the patient. Here's the situation. These are again guidelines. These are not legal decree. From a pure guidelines perspective, you can potentially cause harm. But there are situations where the patient actually had 10 years ago had an intracerebral hemorrhage with known cocaine use at that point in time and had a very high spike of blood pressure. And since then, in the past 10 years, has been living great. Are you going to consider that? Even if you're considering that, you have to at least disclose that it is against the guidelines. And secondly, you have to have a very good discussion about risk and benefit. In general, I avoid it. Any person with a history of intracerebral hemorrhage, we do not give TPA. Similar reason is any person who had a recent stroke within the last 3 months. The reason is that there's a fresh bruise on the brain, and if you're going to open up with the TPA some of these smaller arteries, the chances of that particular person developing a symptomatic intracerebral hemorrhage is high. So in those situations, if you should avoid it. If there's again an extremely minor stroke that actually is fully recovered, there's nothing on the CAT scan, that is something that you need to have a discussion with the family. And now coming with a large hunkin NIH stroke scale of 18 with complete aphasia. At that time, benefits and risk discussion is warranted. However, in general, TPA should be avoided. And if you have other options like large vessel occlusion that can be thrombectomized, you should consider that as compared to TPA. Severe head trauma is a real big issue because patients who have severe head trauma have known to have diffuse axonal injury. As a matter of fact, we have seen blossoming of contusions days after their initial event. And therefore, their chances of having a bleeding event in the brain is significantly higher. Therefore, severe head trauma, defined in my opinion, is simply there is a radiological evidence at the time of head trauma or within the first 48 hours of head trauma with a radiological bleed in the brain. It could be subdural, epidural, even subarachnoid, whatever that case may be, or contusion. In all these cases, if it was within the last 3 months, do not give TPA. As the brain has significant diffuse axonal injury, and giving TPA in these patients can cause harm and not benefit. If there's acute head trauma, absolutely not. Again, sometimes the CAT scan is not showing it, but if you can see a big hunkin scalp hematoma that the patient is coming in with, please don't give TPA. Because again, the similar problem happens that within the first initial CAT scan, you may not be able to see the bleed. But within the next day or so, we frequently see blossoming of the contusions. So be very careful in giving TPA to those patients. And if you have a clear history of acute head trauma, TPA should be avoided. Now let's come to any surgery. So as far as surgeries, traumas, and intracerebral hemorrhages, intracerebral surgeries, and intraspinal surgeries. Any surgical intervention that has a dural repair, that you have to open up the dura. Surgically, you have to open a dura. If it happened in the last 3 months, do not give TPA. I'm not talking about a lumbar puncture. I'm talking about a surgery that opened up the dura. In those situations, absolutely do not give TPA. History of intracranial hemorrhage or current intracerebral hemorrhage is, of course, a contraindication. Subarachnoid hemorrhage signs and symptoms, do not give TPA, like a severe sudden headache that caused you to have, and then you have some neurological deterioration. In those situations, if you are really worried about a subarachnoid, make sure that you have completely ruled that out, because there could be a sentinel bleed, and then you give TPA and then the patient can die. So with patients you are thinking that there are signs and symptoms including, nuchal rigidity, etc., you have to be very careful to at least understand what the symptomology of the patient is in regards to neurological deterioration. And if there's any subarachnoid hemorrhage possibility, do not give TPA. GI malignancy and GI bleed within the last 21 days, do not give TPA. And if the patient actually has acute GI bleed, of course, that is also a contraindication to give TPA. But if it is not acute, if it is more than 21 days, go ahead and give TPA. Coagulopathy is actually a bigger issue, but in general, we do not have enough data, according to the guidelines, if the platelet is less than 100,000, if the INR is more than 1.7, if the PT is more than 50 seconds to give TPA. So if there is any coagulopathy, generally speaking, it is not a good idea to give TPA. However, having said that, if the patient is known alcoholic with a known platelet count that runs in 60s for years, and you can see it in the chart, yes, you should consider it. Yes, you should consider it after talking to the patient, disclosing that this might be, this is out of the ordinary that we are going to give TPA, and they need to understand the risk and benefits before we go ahead and do that. In those situations with chronic thrombocytopenia with a known alcoholic reason and stuff, you can actually talk with the family. Anyone with the INR of 1.7 and anyone who is on a full therapeutic dose of low molecular weight heparin, or anyone who is on a new direct oral anticoagulants within the past 48 hours, do not give TPA. I have heard reports of it. I have actually seen published papers that people have given heparin and then reversed it and then gave TPA. I have personally done it in a patient who had a recent, cardiac angiography that is done. I know that this was procedurally given the heparin, and then the patient actually developed a stroke. We reversed it and then gave TPA. That's a separate issue. But in general, if the person is actually on anticoagulation for anticoagulation, do not reverse and give TPA. There is no indication for doing that in this situation. That's a completely different category. Again, that is something you need to have a very good discussion with the family about bleeding risk in the brain and then consider doing it. However, in general, with known coagulopathies that are going on for some reason, for example, low platelet count in alcoholic patients, that's a different story. But everything else, for any other reason, you should not give TPA. However, if you do not wait for the results either, you start the TPA, and if the results come back and they show that the platelet count is low, then you can stop it. You do not hold up the TPA administration for finding out if the patient does have any coagulopathy or not. So that is also very important, that you do not delay administration of TPA, but as soon as you find out, you can stop it. However, in some patients, when you actually have known, low platelet counts, as I told you, you should still consider it. Now, concomitant abciximab use, do not give it. Concomitant aspirin, that means that you give aspirin while you're giving TPA, do not. If the patient is already on an aspirin, that is not a contraindication. Infective endocarditis is hard to know, to be honest with you, right away. If the patient has infective endocarditis, of course, you don't walk around with TEE probes to see if the patient is on endocarditis. But clearly, if the patient looks bacteremic, the patient looks septic, the patient has very high fever, and then you are concerned about infective endocarditis, or the patient already is admitted in the hospital with infective endocarditis and develops a neurological decline, you do not give TPA to those patients. The chances of patients bleeding in the brain is significantly high. So in those cases, do not. Similarly, aortic arch dissections, if the patient is actually coming with a sudden aortic arch dissection, they're going to need massive surgery. you're not going to give TPA to those patients. And therefore, in these situations, hold off on the TPA because they're going to basically need a rescue cardiac emergent surgery to actually go ahead to stay alive, to be honest with you. And of course, patients who have intraaxial, intracranial tumors like GBM, gliomas, etc. This is not meningiomas, which are extradural. We are talking about intraaxial. Sorry, my apologies. It's intraaxial tumors, not extraaxial tumors. So in those situations like gliomas, GBMs, etc., do not give TPA. However, if the patient has a history of meningioma or has a meningioma, you should give TPA. Now, when these were the things we discussed about contraindication, practically near absolute contraindications as far as TPA is concerned. These are considered absolute indications. So in those cases, if you're not adhering to a guidelines, which is possible, which is fair, and which is fine, again, these are not legal decrees. What you need to do is, again, have a very good discussion with the family, document those discussions and the reasoning behind it to give TPA. Similarly, in these situations, if you're not giving TPA, there should be a very good reason for it. Because in these situations, if you're not going to give TPA, then they're going to be in trouble. And those are, if the patient actually has a disabling stroke that comes in within the 3-hour window. Generally speaking, within the 3-hour window, it doesn't matter what the age is. It can be above or below 80 years old. And if it have a mild stroke, that is an IVtPA stroke scale of less than 5, but it is significantly disabling. And this could be a little bit tricky. Now, if the person is coming in who's a pianist and is having, ataxia, is that disabling to me? Clearly, he cannot go back to work. That is the return to work definition. So, and that's also going to be discussed in the next lecture. But what I'm trying to say here is that there's a lot of judgment that goes into deciding what is disabling stroke and what is not disabling stroke. So that could be individually done. But generally speaking, an IVtPA stroke scale less than 5, and two things: return to ADLs, return to work. And if that's not going to be on the table, then the patient actually has disabling stroke. Now, patients who are within the 3 to 4.5 hour window has a different criteria. And the criteria is different in the sense that if they have history of diabetes, if their age is above 80, again, all those are still into consideration. In general, people are putting all this together, but there is clearly a different criteria for those patients. One of the biggest one is age less than 80 and then a stroke scale less than 25 for sure. And if those criteria are met, then you can consider giving TPA to those patients. Generally speaking, people are more and more giving TPAs up to 4.5 hour window. And of course, give it as quickly as possible. The blood pressure should be less than 185, diastolic less than 110, as we discussed in the last lecture. Blood glucose level should be above 50 to make sure these are not stroke mimics secondary to hypoglycemia. Patient's CAT scan is done and does not show an intracerebral hemorrhage clearly. And if the patient is on any prior antiplatelet therapy, any antiplatelet therapy, it does not say if it's a monotherapy, then there is a small increased risk of symptomatic intracerebral hemorrhage. However, we know that, we still give that. And if the patient is on aspirin and Plavix, you should still give TPA. Now, Berlinda is a separate issue. We don't have enough data about it. Some people are on Berlinda. People say that there's a higher increase of subdural hematomas with Berlinda when you give TPA, or increased risk of intracerebral hemorrhages. Either way, deriving from these at least guidelines, if the patient is on monotherapy of Berlinda, then you can consider giving TPA, as it is at the end of the day an antiplatelet therapy. Patients with end-stage renal disease is not a contraindication to give TPA, and you should give TPA to those patients. Now, these maybes are much more complicated, and we're going to discuss in the following lecture. Thank you for your time. Thanks for your time. Please like, subscribe, and share. Follow me on LinkedIn and Twitter.